This is a dislocated native lens due to Marfan syndrome. After I create a paracentesis and a main incision, I now perform the capsulorhexis. And this is the most difficult part of the surgery because of the missing zonules to the right side of your screen, but also to the bottom part of your screen. But you can see that the step goes uneventfully. Now I'm going to perform hydrodissection and then hydrodelineation. And now I'm going to add two capsular retractors to basically bring the lens back into center. And then I'm going to add a third capsular retractor for added stability. Now, the cataract itself is very soft, so I'm going to basically remove it just using IA. And you can see that during this step, there's excessive capsular folds and laxity. And this is just not a good bag to use long term because this patient is very, very young. And so now I'm going to basically strip away all the residual zonules by just basically pulling towards the center using the micrograsper, and basically do that across every quadrant. And once I feel like I've liberated enough of the zonules, I'm now going to remove the capsular retractors, and you can remove them either through the main incision or through a paracentesis. And so here comes the third capsular retractor, and the fourth one will be removed through the main incision. Now I'm using a micrograsper to remove the bag, and then I'm going to perform anterior vitrectomy again. And now I'm going to mark for the Yamane technique, measuring halfway across the corneal diameter, 2.5 millimeters across. And then I'm going to now insert the 3-piece IOL, and then I'm going to hold the haptic with a micrograsper with my right hand. With my left hand holds the 30-gauge thin wall needle, and I'm basically cannulating the haptic into the lumen of the 30-gauge thin wall needle, and then I'm going to repeat the same thing on the other side. And now I'm going to basically externalize the haptic, apply low temp cautery to create a very, very small little flange, and then I'm going to do the same thing on the other side, just a very, very small little flange, and then I'm going to tuck the flanges once it's created back into the intrascleral tunnel. You can see the lens centers quite nicely. Here I'm removing the viscoelastic manually, followed by repeat anterior vitrectomy, and then hydrating all the incisions. You can see that the IOL is well stable. Postoperatively, this patient achieved uncorrected vision of 20/25, and you can see that the IOL is stable and well centered.